to our Building a Culture of Community Engagement speaker series. We're glad you can join us. We have a wonderful panel of speakers who'll be presenting to us this evening on engagement, equity, and vaccines. I'm Linda Sprague-Martinez. I'm the co-director of the Community Engagement Program at the Boston University CTSI. I'm here with my colleague, Tracy Battaglia, who is the co-director with me as well, and Dima Hakim, who's our program manager, Jennifer Pemphil, and Rebecca Lobb. So we're really excited to be here with you this evening. We're gonna jump in and get started. We have our 4 panelists this evening. We have Lenita Reason, who is the executive director of the Brazilian Worker Center, Cristina Araujo Brinkerhoff, who is on the board of directors at the Brazilian Worker Center, also a doctoral student in the Boston University School of Social Work. We have Dr. Katherine Gergen Barnett from Boston Medical Center, as well as Dr. Rebecca Perkins from Boston Medical Center. So really excited to have everyone with us this evening to learn a little bit about vaccines, vaccine equities, and engagement, and how do we use engagement to ensure equity. So with that, we'll click to the next slide, where we'll let you know the objectives for the evening. And we're really going to explore a spectrum of community engagement strategies for advancing vaccine equity. So click. Our first speakers, I already introduced the panelists, I'm ahead of myself. Our first speakers, though, that we'll hear from this evening are Lenita Reason and Cristina Araujo Brinkerhoff. We'll then move over to hearing from Rebecca Perkins, and then Dr. Katherine Gergen Barnett. So with that, I will turn it over to Cristina and Lenita, and we have your slides. So.
Hi, everyone. Thank you very much, Linda. As Linda said, I'm Cristina Brinkerhoff, and I am a doctoral student at Boston University, and also have been a member of the Brazilian Worker Center since 2015. Our work is titled, it's like getting vaccinated at their home, community organization strategies for COVID-19 vaccinations for immigrant communities. As we
You are muted for some reason.
Sorry, I'm sorry. As I was saying, communities of color, including immigrant communities, were among the highest in rate of infection, hospitalization, and death throughout the pandemic. Additionally, they also experienced significant barriers to vaccine access. And that's why the Brazilian Worker Center act to provide this to provide vaccination for the community. But before we start talking about the program, I will pass to Lenita, and she will talk a little bit about the Brazilian Worker Center. Can we go to the next slide, please?
Good afternoon, everyone. My name is Lenita Reason. Now I am the executive director at the Brazilian Worker Center, but for many years, I work at the Brazilian Worker Center in different roles. I started as a volunteer, then I became a workers' rights coordinator, then a health and safety coordinator, then an office manager, and now I'm the executive director. So the Brazilian Worker Center is a nonprofit organization that was created in 1995 for worker by workers. So the workers, immigrant workers in Massachusetts didn't know much about the laws, the labor laws, where they could go if they have any things that they need support with, like housing, immigration, health, problems at the workplace. So a group of workers started the Brazilian Worker Center. Since then, so our major work is supporting and working, organizing, and educating the workers on issues at the workplace, rights, immigration, health, and so many other things. So something changed with our phone start bringing crazy. So people want to know if that they saw the TV is true, if they saw on the radio and it's true, if what people telling about what they should do it. So that was not different when the pandemic is starting and about the vaccination. For the last now, I think it's going on to 3 years, right, since the pandemic started, since the schools shut down. So the Brazilian Worker Center shifted the work a little bit because of the needs of our community. And we are the Brazilian Worker Center, but we not only serve Brazilians. So we have Latinos, we have many Asians, Middle Eastern. So anyone that comes to our office, we're trying to do the best we can to communicate with them and to support them. So with the pandemic started, so we shift a little bit to give people assistance, immediate assistance, because many of the community we serve, they didn't qualify for government support, and they could not be work from home. So we never closed. We never went to close our door, we went to work remotely. So we kept our door open throughout the pandemic. I have to step out for 50 days because I got COVID, almost died, got really sick, but I came back right away as soon as I felt better, and the work continues. So we support people with food, diaper, cash assistance, rent, and anything else that they was coming to us looking for. When we couldn't provide, we was find another partner that could help them. So, and then 2021, we started with the vaccine as soon we was able to have it resource and had someone to support us with that. So next, please. Cristina, you want to do this one?
Yes, definitely. In order to understand what the Brazilian Worker Center knew about like the Brazilian immigrants' background and culture, for them to start like a vaccination campaign, it's important to understand the history of vaccination in Brazil. Like Brazil had developed in 1993 the National Immunization Program, which is a program that provided mass vaccination for the whole country, for children and adults. And with that, like Brazil was able to eradicate polio, rubella, and reduce death by vaccine preventable disease in one generation. And as I say that like with sadness, because of this investment and because of like mismanagement of these last 4 years of this government, we have seen now after 40 years case of polio in Brazil in this last year. So I type that and I say with sadness that now we have a case of polio in Brazil. But with that said, like Brazil has a robust history of mass vaccination, and that is also like in the Brazilian mental history of the Brazilian and in the culture of Brazilians, like the history of vaccination. And so much so that we even have like a mascot. We have Zé Gotinha, that in 1986 got introduced to the vaccination campaigns in order to make kids feel at ease with vaccines, because kids used to be afraid of the vaccines and of the drops of the polio drops. So taking that into consideration, like the Brazilian Worker Center already leveraged that to use that for their campaign. Next. We can go to the next. So what we did for the methods for this qualitative study was a case study of the vaccination campaigns of the Brazilian Worker Center and the partnership that they had with healthcare organizations to provide vaccination. We analyzed documents from the vaccination clinics, social media posts from the Facebook, from the Brazilian Worker Center Facebook, from Brazilian Worker Center Facebook page, and also perform interviews with organizational leaders. The analysis was made as a holistic case, embedded analysis of specific cases of the case, specific parts of the case, as well as thematic analysis of the qualitative data from the interviews. And as for the results, like I will have like Lenita talk a little bit about the process of the vaccination since she was actually there.
Yeah, so the process, I like many of the programs that we have to respond at the center. So people start calling us saying that they was trying to get vaccinated, but they have to show ID, they have to show insurance card, and some people didn't have insurance, and they was being denied. And we was explaining to people the age, right? Because when the vaccine started, started with certain group, but people was in the group and the age appropriated. So they was like, no, this has nothing to do about that. So we start investigating what was going on, and then we reach out to our partners. So we reach out to Lawyers for Civil Rights Boston to understand what was going on. And they said, do you, if the Brazilian Worker Center wants to bring the clinic to York, so we can help with that. So we said, of course we want it. So they was able to connect us with the clinic, and we scheduled the first day of vaccination. So at the first day of vaccination, they was like, okay, if you can have 250 people, 3 people per minute, so we can be there. So we said, okay, so we get our list of members, because we have a system of membership at the Brazilian Worker Center. People can support us paying $40 a year to become a member, and any program, anything that comes to the center, so we reach out to the members first. So like, for example, when DACA came up, so we reach out to the members and say, if you're qualified for DACA, so you have priority in our list. So the vaccine was the same thing. We say, first, we're gonna give the opportunity to the members, and then we're gonna reach out to the whole community. But if someone doesn't have $40 to become a member, they can still become a member, so unpaid member, and then they can just volunteer, comes for meeting, anything that we do in the center, and they're going to be a member anyway. So we reach out to the members, and as soon we call the first 10 people, so so the community was like, the Brazilian Worker Center is having vaccination, and the phone didn't stop ring. So we had to create a waiting list, and we was able to get the 250 people for the first clinic, and we already had the list for over like 300 other people and we didn't know if we would be able to have other clinics at that time. So we was doing step by step. But as well, we put on our Facebook page, and the members start talking about it. So our executive director at the time, Alicia, she did a video recording, put on Facebook. And the day of that vaccine, so we have the huge line in front of the center. But we have to, the clinic was come with the nurses, the computers, and the vaccine. But we need to have people to help with language justice, right? So we had to translate. We didn't have only Brazilian comes. We had Brazilian, we have Asians, we have Latinos, so Spanish speaking. So we have some volunteers from the community. We have the whole staff, and we did that day that went up from 9 a.m. to 6 p.m. And at the end of the day, 6:30, at the end of the day, we had 250 people vaccinated at that day. We use Facebook, Instagram, and I think, but most what happened was the community that know us, and they feel comfortable coming to the center. They knew that they would just come there. So we call everyone, and we have like people every 5 minutes at that first time we said. So every 10 minutes, we're going to have 3 people, because that's what we were told. But when that happened, in reality, wasn't that easy, right? Because you have to register, the nurse have to go through everything that they need to ask, you have to translate. So was a little like difficult than what we expected, but at the end of the day, nobody was complaining for being on a cold day, because it was still March. Everybody was happy, everybody was treated the way they deserve to be treated. We had coffee and pão de queijo in our kitchen, because Brazilian, so we always have to offer something to eat. And so it was a successful day, and was very grateful to see our community to have access of something that was being denied to many of them already. Next.
Okay, so the Brazilian Worker Center, like Lenita said, like they did a total of, at the Brazilian Worker Center, they did a total of 15 clinics. They did that first. They didn't know if they would be able to do more, but they did a total of 15 clinics at their site, and vaccinated at their site a total of 1,681 people. No, of 81 vaccines, not 81 people, I'm sorry. And they also provided support for vaccination with cultural brokering and translation at other places, at the Reggie Lewis Center in Roxbury, at the Madonna Queen Universe National Shrine in East Boston, at a playground in East Boston, for a total of 1,925 vaccinations. Like Lenita said, like this is not something that they do. Like this is not like at their job that was outside of their comfort zone, but that's something that they provide to the community. Like even though there's not something that they actually do, and they were like very successful in doing. Next, please. So some of the lessons learned is like that the Brazilian Worker Center leveraged their established networks and cultural assets. Like they had the Facebook, they had the members directory, they had the Facebook people that follow them. I think that the Brazilian Worker Center have over 8,000 people that follows them on Facebook. They had the familiarity and trust of the population, so they could mobilize people quickly, and they were able to provide culturally and linguistically appropriate services, which is important for a population that not always speak English as their first language, or not always speak English at all. Also, very important to go with that is flexibility with identifications for immigrants that are unauthorized. Even though, like in the places of vaccination, they say like that you are supposed to, like they are supposed to accept the identification that you have to provide. They are not always sensitive to the fact that not every immigrant have a Massachusetts ID or a Massachusetts driver's license, which for immigrants, a lot of immigrants, what they have is like their national passport or passport card, which for Brazilians looks something like this. And here is the bio, and the top is in English. It is a federally recognized ID, but when you go like to a place and you have to explain like what your identification is and why you're providing this identification, it's very exposing, especially if you are like in a country undocumented. So it's really comforting to not have to explain yourself, not have to expose yourself, and go to a place where you feel welcome, where you don't have to explain yourself. Next, please. That's all. Thank you.
Thank you so much, Lenita and Cristina. Wonderful presentation. So many important points. I love the Zingote and the work that you did. We're going to save questions for the end. And now I'm going to jump right over to Dr. Perkins for her presentation.
Great. Thank you so much. Can you guys hear me okay?
Yes.
Great. I'm going to try to share my screen and then see if I can get this in presenter mode. Okay, there we go. So this is our CTSI grant. We interviewed healthcare workers and surveyed them about COVID-19 vaccine attitudes and message preferences. And my co-PI on this work was Natalie Pierre-Joseph, who I've worked with for really close to 20 years at this point. We've done a lot of work together on HPV vaccine and now moving into maternal and COVID vaccinations. She may be listening in tonight, and we'll be happy to answer any questions that we don't get to tonight over email, certainly. And then we had two wonderful research fellows, Shayna Burrows, who was a postdoc and is now hired on as an assistant professor, and Sharon Casey, who was an MPH and is now a BU PhD student. So we had, and they both had babies. So we had like a really big year on our project. We had a fantastic community stakeholder advisory board, which included people from all over Massachusetts, from various different specialties, different clinician types, public health. And so this group was instrumental in helping design the project, input on surveys, participating in interviews, tapping their networks for survey participants. So really helping us get a very wide swath of the healthcare worker population, because a lot of surveys and things focus on like just doctors or maybe doctors and nurses, but only have sort of one group that they're looking at. And as we know, healthcare workers are not one group. We're lots and lots of different people doing lots and lots of different jobs. And we're one community, and we felt it was really important to tap into as many different people in that community as possible. So our project aims were to understand factors affecting healthcare workers' readiness to accept vaccination for themselves, as well as identify informational needs to facilitate vaccination, and also understand factors affecting their willingness to recommend vaccination to others, and see what messages were preferred by healthcare workers and also what they found were more acceptable to their patients. And then as we sort of moved through the project, we asked about strategies to improve vaccination, and then came upon this huge problem of the mental health impact of COVID. So we actually did an unanticipated third part of the project on that, because it was something that was just too big to ignore. So the first project was figuring out attitudes toward vaccination. And when we asked healthcare workers why they vaccinated, they felt generally very accepting of the vaccines. They felt the vaccines were safe and effective, even early on. After looking at the clinical trial data, people were very excited about it. They wanted to protect themselves, had a high feeling of being at risk at work, wanted to protect their families, their patients. And healthcare workers also had the strong sense of being a role model for their patients, for their families, for their communities, and really feeling like they needed to step up first to get the vaccine to show everyone that it was okay. Some facilitators of vaccination were staff education on vaccines from trusted internal sources. So, we had so much great work going on at BMC. And so you'd have the head of the infectious disease department who was like running the clinical trials and on the phone with the CDC every week and knew everything that was going on and could tell people exactly what was happening with the most up-to-date information that there was. And people really liked that and trusted that because it was someone that they knew. And so that was really helpful. So the healthcare workers generally got the information they trusted from an expert at work, not from social media or the news or some other source that often gives information that we know is maybe not the greatest information. And then there was also, they talked about a positive peer pressure or social norm of everyone getting vaccinated at work. And I mentioned that their sources of information tended to be primary sources, so research articles, as well as workplace communications, but really not from social media or the news. They reported, not surprisingly, that patients were very concerned about safety and side effects, feeling that the vaccination was rushed, early concerns about fertility issues or other long-term side effects. And we had some great quotes that I won't take the time to read here, but just talking about that dichotomy of some people thinking that this was such a great scientific miracle, and other people were saying, how could you possibly get this done this fast? There must be something wrong with it. And then there was a very strong theme of race-related medical mistrust, where people in the Black community worried about the vaccine being something that, instead of being helpful, was actually going to be harmful to them and their community, and that causing a lot of mistrust. Then we asked about people's ideas on different strategies to improve COVID-19 vaccination. And we did both interviews and surveys. So the interviews were done in the spring of 2021. So this was right after we had gotten through the alpha wave and when vaccinations were becoming available to everybody, and when we thought vaccines were going to be the answer and wipe everything out. The surveys were done in the spring of 2022. So at this point, we had the alpha wave, we got vaccinated, we had the Delta wave, which wasn't too bad because we were all vaccinated. Then we had the Omicron wave, which was horrendous despite the fact that we were all vaccinated. And that's when we did the surveys. So the world, the COVID world that people were living in when they answered the interviews and the surveys were very different. The interviews also happened before we had healthcare worker mandates for vaccination. So we asked healthcare workers how they felt about vaccine mandates for healthcare workers. And in the interviews, about half supported it, a third opposed, and 23% were somewhere in the middle saying maybe this, but maybe that. And when the surveys were done, even though vaccines were now proven to be less effective, because it was sort of the norm, the support was higher, 63% supported the mandates, but a third supported mandates only if the alternative was masking and testing, not job termination. And 7% opposed mandates under all circumstances. When we asked people what they thought were and people also have very nuanced ideas about incentives. People were afraid they would be viewed as coercive or maybe increase mistrust, because why would you give someone money to get a vaccine when that's a regular health behavior? But then people felt favorably about, well, if you give someone a, free transportation or, a meal or snack or something when they get there, that was viewed to be helpful and not coercive. So the incentives really varied depending on what they were. But what people really thought was effective was going to be actually giving people the information that they needed. So addressing misinformation, discussing vaccine safety, and then tailored community outreach in areas with lower vaccination rates. So sort of I talked about before, in the hospital, the healthcare workers got their information from the ID attending that they really trusted and who knew everything that was going on, and that was their trusted source of information. Out in the community, that person may not be the right source of information, but there is going to be someone who is a trusted source of information, and figuring out in each community who is the trusted source of information and how can we work with them to help get people vaccinated and keep them safe. So those were a very rapid summary of our COVID vaccination projects. And then we come to mental health. We didn't intend to ask about this, but it's a huge problem. So people talked about the toll of experiences, excessive deaths during the surge, the fear of being constantly exposed to COVID at work. People told us stories about limited PPE at the beginning of the pandemic, using garbage bags, reusing N95 masks, not having the same quality of mask for the different members of the healthcare team, being overworked, being exhausted. Then when we got to the surveys a year later, over half of the healthcare workers reported their mental health as worse than before the pandemic. Almost a third had a new or worsening mental health condition diagnosed in either themselves or their families, and a fifth had to take time off of work for mental health concerns. So, I mean, these numbers are just staggering. About 28%, almost a third, reported an increase in the weekly hours worked, and 80% reported staff shortages. And this is something that we have all felt. We are down doctors, advanced practice providers, medical assistants, reception, ambulatory staff, environmental services, you name it, we don't have it. And about 60% of our healthcare workers report feeling burned out at least once a week, with 1 in 5 feeling burned out every single day. This translates into the attrition that we're seeing from healthcare. So in our study, about 35% of participants intended to leave healthcare in the next 5 years, and that about a third of our participants who are under the age of 30 intended to leave. So the 18 to, I think it was 35, the 18 to 35-year-olds were the most likely to want to get out within 2 years, which is also terrifying because those are the ones who you need to stay because they're going to have the longevity in their careers. The second most likely to leave soon, of course, were the ones who were close to retirement, but that is more so to be expected. And the mid-career people were the most likely to stay, I think, because at that point, you're so trained up, you don't really know where to go. A quote that really resonated was, "I want out. I know I'm burned out, but don't see another job I'm easily qualified to do. I feel guilty leaving the other doctors, knowing that my leaving will make their jobs even harder. I'm worried about the future and the supply of doctors." When we asked people what contributed to burnout, 85% said that insufficient pay and salary was contributing. And when we drilled down on this, it's basically, you're not paying me enough to do this job. And it's about feeling undervalued by the healthcare system and leadership, because this was insufficient pay and salary was the #1 reason in every single type of healthcare worker: doctors, nurses, medical assistants, EMTs, social work, mental health, no matter what, which meant it wasn't actually about the salary. It was about what the salary meant in relation to the difficulty of the job. 78%, 4 out of 5, felt that supervisors and the company, the medical institution, the healthcare system was not supporting them adequately, and that was why they were burned out. And then another, also about 4 and 5, said they didn't feel like they were able to provide the type of care their patients needed due to various things, but one of the huge contributors being the short staffing. And this contributes to something that's actually a military term called moral injury, which is when you bear witness to something that is wrong. So essentially having a patient who you know how to take care of, you know what care they need, and in the situation that you are unable to provide it. And that is what our healthcare providers are feeling right now. We asked what can we do to address the burnout in healthcare. Again, the most common answer was higher salaries, but just as high really were flexible schedules, allowing people to work from home, work different hours, do something that would allow them to take care of themselves and their families, and then being able to avoiding that moral injury, being able to actually take care of our patients in the way that they deserve to be cared for. And so that is the end of our project, and I would be happy to take questions at the end.
Great. Thank you so much, Rebecca. Very powerful, powerful quotes and powerful data that you have there. I'm going to turn it over now to my colleague, Katherine Gergen Barnett, to present, and then we'll do some Q&A at the end. You're on mute, Katherine.
That was such a rookie move.
It's 5:37.
I was like, I was just saying how much I resonated with Rebecca's quotes, having just come from a full day at clinic and, with patients writing letters saying, "Can I please get in?" So the lack of access is powerful. So grateful for all of your work. So, I wanted to take this moment actually to share about what we've been doing and really kind of building on the work that you all have talked about, and not just around the vaccine, but we took this opportunity, and I'll share a little bit about my amazing community partners that I've had a chance to work with, to really say, okay, this is, the call to action is around vaccines and working in communities. And we were really focusing on what a lot has come out now on the medical distrust and how that's sort of at a cornerstone of this vaccine work, and wanting to go upstream to sort of explore, more of where the community is at with the medical distrust, and using restorative justice and stories to do it. So I wanted to just take a moment. You can see a lot of people's logos on here. Really a huge thank you to CTSI. And I see Tracy is here, Rebecca, and obviously Linda for the funding for this. But we've worked extensively with Transformative Prison Project, the Black Project, Everyday Boston, and I'll share each of their roles. And both Rebecca and I are part of SEAL, which I see Hope is here as well. So that's been a great collaborator. So let me, Dima, thank you for having my slides. If you want to just go to the next one. So I just have a few slides, in part because really what I want to take some of our moments together is actually listening to a story, because their folks' words speak much more powerfully than mine. So this was really around three different parts. So we had three aims for the work that we are going to be doing. One is identifying barriers and facilitators of engagement in health systems. Two is developing capacity building materials to really improve medical systems and engaging community, really focusing specifically on folks who identify as BIPOC. And three, to disseminate these lessons with our community partnership. On the left, you see a woman named Cheryl, and she gave her permission to use this photo and her quotes. And actually, we have several videos of people telling stories, and we're gathering more. But you also get a chance to hear her story, and really saying, "Hear me, see me, and trust me." And I like this quote too, because all the books in the world can't tell you what my body is feeling and what I'm going through. Next slide, please. So our process is a little bit small in terms of the font, but really wanting to walk through the three different parts of it. So the first is really to bear witness, acknowledge the toll that racism has played within our healthcare system. Obviously, I think we are all, or so many folks are doing a reckoning, but how do we do it more than just writing papers about it or, kind of marking it? And so for us, it was doing restorative justice, and I'll share a little bit more about what restorative justice is and how we did that. And then the second was actually to be doing a story collecting project. So we are doing individual stories with community members about people's experiences in the healthcare system, and garnering those stories in a kind of more informal way, but video recording them. And step three, which we're actually doing now, is putting these all together for a curriculum for healthcare providers, and working with community members to do that. Okay, next slide, please. So the first is this restorative justice circle. So I don't know if folks are familiar with restorative justice. It's, really had its base here in the United States in the legal system, but is an ancient tradition and it has been, used in places like South Africa as well. But this idea that the perpetrator and the perpetrated against are really in dialogue with one another in a facilitated manner where there's an ability to, there's a question, a basic question that gets asked of everybody's that is there. And there is ground rules, like every circle, so that people can share their truth. And there is a lot of evidence of healing that happens through these restorative justice circles. And this is where I worked with the Transformational Prison Project. And these are folks who have all spent time incarcerated and learned the restorative justice methodology while they're incarcerated. So they were the leaders and guides, and I've been just, so humbled by their teachings. And so we did 3 different restorative justice circles with community members and with folks from the medical community, including Ben Linus, who's the PI for the SEAL, and several different folks who work at BMC, but not just at BMC, other healthcare systems as well. And each of these restorative justice circles were recorded with the permission of folks who were there. And then we did qualitative analysis of what came out of that. So that was phase 1. And then next slide, please, Dima. So many quotes. I just picked this one, and themes that came out of it from the qualitative analysis. So this quote of saying, "I can say that many times I haven't been believed or respected just because I'm a brown woman in a medical setting. I've had white female nurses who don't believe my pain, or, were very surprised. Quote, 'You're so articulate.' So these microaggressions and little things that people do to show they're inherently racist is very damaging and very violent." So one of our main themes was around this negative experiences, microaggressions, being undervalued, stereotyped, building on this medical distrust. Next slide. So, and I'm really happy. I just knew this was such a little micro taste of each of our projects. So I'm really happy to share so many more quotes. The next stage, which we are still doing, but have gathered a lot, is 2 different story collecting projects. So we worked with a professional film company called Avedisian and did 3 short videos and put that together as a package with people's stories, and we're sharing those, and I'm happy to share a link. And then we've been working with this amazing group who I've been partnered with for a few years now, called Everyday Boston, where it's about strangers collecting each other's stories. And so Everyday Boston has really been the lead for all of this work, and they've been interviewing people who have a story. We're trying to get different ages, different backgrounds, again, folks who identify as BIPOC primarily, and using those stories and collecting them. And I'll share a little bit more about what we're going to do with those. Okay, next slide, please. So this is, I wanted to spend 3 minutes to share one of those stories. And this is Cheryl, who gave us permission.
There's no way, and Kamal, I mean this so seriously, there's no way that I should be so grateful to be cared for by the medical profession that I have been in the last year. All those years before, it was like, I keep going, and I'm begging you people, just help me. Keep me out of the emergency room. For the 2 years, it seemed like every other month I was in somebody's emergency room with the same results. We're trying to find out what's wrong and make sure you keep the follow-up appointment with your primary care doctor. It was so difficult for me that when I left the hospital that I was at before, I wrote these doctors a letter telling them why I was leaving, telling them that I thought that their care was inadequate, that they suffered greatly from a sense of humanity, and that they just did not serve me well. And that, I've never done anything like that. Who would think that you fire doctors, and certainly not in writing? What people do is they just don't go back to that doctor, and they find it was that important for me, for them to know why I was leaving, because they hadn't taken care of me. Not even just good care, they just didn't take care of me. And that hurt me because it made me look at society as a whole it made me look at being a Black woman who always thought of myself as being so strong. And those people crushed my spirit because they made me feel like I was less than. And that hurt because I couldn't figure it out, because I knew that I deserved better. So I need hospitals and doctors to know that everyone deserves the same treatment. And I'm not just talking about adequate treatment. I'm talking about treatment that's going to treat the whole person and not just with a prescription. I can't tell you how much money I've spent in copays on prescriptions and the stuff didn't even work. That's the bottom line to it. You know why it didn't work? Because they were checking the boxes off and they really weren't trying to find out, in my opinion, what they were treating with me.
Thank you. So I think it's the final slide. If you can go forward one more. So we're now in using kind of amplifying these stories, creating a website, but we're also working with actually medical communities. We're working with We Got Us, who is a partner for SEAL as well, to create a curriculum and piloting it at Harvard Medical School, hopefully BU as well, and working on displaying exhibit with other interactive events, and eventually working to make a Bill of Rights for patients and tip sheets for providers. So this is obviously, there's so much that could grow from this. And again, just really grateful for this opportunity and for the amazing partners that I've gotten to work with on this. I'm confident that it will continue to grow. Okay, I think that's it. Thank you. Yeah, big thanks for all of the partners.
Well, thank you for a wonderful, wonderful, powerful presentation. So many amazing presentations this evening. I'm looking at our time. We have about 10 minutes. And so I'm going to open it up to the audience for questions. I'll chime in with my questions too. I'll call on myself in an equitable fashion. But maybe we can start there. I know there were things that were coming up in the chat for folks. Are there questions? Y'all are just here for the networking? Quiet? No, just kidding. Tracy?
Yeah, I can ask the question I put in the chat to our first speakers, which was really around, you guys had such amazing success in delivering services to your community that you had no experience delivering in the past. And I just wonder if you could speak to the relationships with other stakeholders that you needed to cultivate in order to be successful. Like who were the other partners that you were able to sort of work with?
Lenita.
Yes. Yeah, so Lawyers for Civil Rights was the first one that introduced us and connect us with the clinic. And then after we did the first one, and the Sussex was the first one, so the clinics just like, do you want us to come again? And then we built. So the Wheeler Health Clinic was the one that did most, and we have another clinic that did once. And for the Reggie Lewis, they invite us to go there. They just send the people to go there and be in there because they will need Portuguese and our community. We are 27 years in our community, so sometimes the government, the elected officials, or some organizations in Boston, like the city of Boston, they doing something for Brazilians or for immigrant community. They ask us just to be there, and they say we're there and people trust to come because they know it's something that they can trust. So it's very helpful. But we as well, so we reach out to other organizations that we knew that probably some of the members in community was not having access. And then we asked the clinic if they could do a different location, and this was the case at East Boston. So we reach out to organization, sent to present and say, do you want to do this with us? And then we went to the Madonna Queen, and the clinic went there with us.
That's amazing. Thank you. It's a really great, I mean, your case study is just such a wonderful, exemplary example of meeting the community where they're at. So congratulations.
I think it's powerful how you describe how you partner. I mean, I'm going to jump over to Rebecca for her question. I just had a question around, you described how you partner with other community organizations like Centro Presente. I know you also partner with the DDC. And I think it's one of the things that this speaker series, we're framing it around creating a culture of engagement. And a lot of times our partners in the communities have this culture of engagement and partnership across organizations. And what makes that possible? And what, in your opinion, and anyone can chime in and answer, and what are some of the challenges of partnering with the large institutions that's different culturally? Like what needs to change to create this more of a culture of engagement and partnership? And then also, so that's the question. It's a big question. And then we'll jump over to Rebecca.
I would say, Linda, because I have been working with many coalitions, and the biggest one that I ever worked was made up of over 270 organizations. So, and this is even we have the same goal, but we have a different ways that we believe that would make us to reach these goals. And think this is what make not a little, but sometimes very difficult, but we just have to be able to have a conversation, to brainstorm and to find the best way that we can get things done together. So this Liaison 4 that you see behind me is an example of 20+ years of work of so many organizations, but by this past 20 years was like only community organization doing the work here or other doing that. And when we came together as community organization, labor organization, business, faith, and law enforcement, and we figured out a way so that we had the same goals and we couldn't find a way so we could work together and figure out a way to do it and made it possible. So, and for the pandemic, we start working, the Brazilian Worker Center, the first time we did food distribution was 500 people show up, and was just like an individual donor that said, okay, go to the supermarket and I pay half and you figure out the way you pay the other half. Like a month after, we have 15 organizations that decide to work together. So we have the first 3 that came together, talk and say, let's invite others, because this is not a problem only of the city of Boston. This is all over Massachusetts. This is all over the world, but we have to think about Massachusetts. So we came together with 15 partners and we're still working together. So now that the pandemic is not over, but it's like people back to work and try to go back, we have find a way to work with legal immigration resource, trainings, share experience, what we're doing. So the 15 partners is still together and we empower each other with and share the best experience that we have. So I think this is what the best that we can do. And we have Haitians, Brazilian, Irish, Somalians, and Americans that is part of those organizations that is working together, in Caribbean. So it's not like one group here. So we this mix of immigrants that it's working together to make better for everyone.
I love that. So many hands, still heavy work, but many hands. So that's really great.
Yes.
I'm going to jump over to Rebecca's hand. So thank you so much, Lenita.
Thanks, Linda. Thank you to everyone who spoke about your projects today. I have to say that I feel that this is the most compelling, all projects were compelling examples of community engagement, the most compelling examples that we've seen at any of our sessions over the past year, 2 years that we've been holding these sessions. So I am just honored to have you all speak tonight about your projects and share the information. My question is for Rebecca Perkins. I am curious about any partners that you have who could work with you to find ways to raise the findings of your studies at the policy level, because there's worker implications, there's state implications, and your data is just so compelling. And I'd love to see you develop a partnership with local unions or other policy groups that could really use that data to drive some policy changes to improve training or the organization of healthcare practice. Oh, you're on.
Thank you for that question. I'm just going to share my screen one more time to so our community stakeholder advisory board was brought together for that purpose as well. So we have Marcela Del Carmen, who's the CMO of Mass General, as well as people from the Mass Medical Society, and other and a few people from DPH. So we are hoping we had 3 meetings to share our findings along the way, and then obviously we'll be circulating the papers through this board as well. But we brought some of these really big, heavy hitters into the community stakeholder advisory board with the hope that that would sort of, rather than you do a survey, you write a paper, it goes into a journal, and then maybe or maybe not a news media picks it up, and maybe or maybe not it does something, that we would actually bring these findings directly to leaders in the healthcare industry to hopefully affect change. Although it may not be a message they want to hear, but it's very important.
No, it is very important, and you probably can begin your list of conferences that you could present this data at right now, starting with the GIM conferences or Healthcare Association conferences. But great work. Thanks for bringing back that slide to talk about your advisory board.
Great, thank you so much. Wonderful questions. I like the idea of the unions as well. Thinking about it. Additional questions for our panelists? Okay. Well, again, amazing work, very powerful. I'm looking forward also, Dr. Katherine Gergen Barnett, to hear your presentation. I think you could make a nice NPR piece of that to get the word out. And it's so important. I mean, the medical education piece is important, but also it's relevant for other sectors. I was thinking about how relevant that would be for job welfare as you were presenting. So really great stuff.
Thank you. Yeah, the Transformational Prison Project has become a real partner, and happily they're doing work in lots of domains. And I actually just put in for a larger grant to do more restorative justice with them. So we'll see. But yes, NPR is, as you probably know, one of my favorite go-tos with dissemination.
I hear you on that.
I just did something last week on worker burnout in primary care, Rebecca. So I should have just brought some of your data with me. I could have.
Had I only known.
Next time you can bring Rebecca.
I mean,
Rebecca with you.
It's very consistent. It's very consistent with what we've seen. So.
Yeah. Well, excellent. So I know we have to break out into we're going to break out into the networking portion, but before we do that, I would love to make a plug for our next month's panel. Dima's so on it right now, like quick with the slides. So building a culture of community engagement speaker series focused on engagement to advance equity. And we are going to hear from the accelerator. So at BMC's Equity Accelerator Leadership, Elena Mendez Escobar, Thea James, and Patrina Martin Cherry. So join us again, bring your friends, and please, we'll share this out. And maybe Lenita, you could share it out to your 8,000 followers. So, and we'll also be sharing the video of tonight's event if you'd like to share it out as well.
And I would just like to make a plug for Thea James. Most people will not get to hear or speak directly with the Dalai Lama, but I feel like if you can't, Thea James is the closest you're going to get. Somehow, like, she